Dear colleagues, this is an unedited teaching video. In this video, I want to show capsulorhexis in intumescent cataract, vertical chop, loading of a multi-piece intraocular lens in the cartridge. In this case, I have used a Technis 3-piece intraocular lens. I have started this surgery. The lid margin has been nicely covered by the plastic drape. We have very good drapes nowadays. Many companies make it and it is quite cheap, but quality is good. Now betadine 5% lotion is applied over the ocular surface and the surface is thoroughly irrigated. This is the main incision. This is a slow unedited surgery and you will be able to follow each and every step. The main incision and one side port incision has been made. The patient is under topical anesthesia and we can see that the eyeball is moving. A big air bubble has been injected into the anterior chamber. Now this is trypan blue dye, 0.6% trypan blue dye, and it stains the anterior capsule very nicely and makes capsulorhexis possible and easy in these in white cataracts. Many years back, when this dye was not available, we used to increase the magnification. We used to put off the tube light or the light in the room. Only the microscope light was on, and we tried to do capsulorhexis in those days where this dye was not available. But nowadays it is very easy with the use of this dye, which stains the anterior capsule nicely. Now, as I incise the anterior capsule, we can see that oily fluid has come out. This initial incision is very important. It should not be a straight incision. It should be a curved C-like incision. If the incision is curved C-like, it doesn't extend to the periphery. But if it is a straight incision and if there is too much intralenticular pressure, it can immediately go to the periphery and you can see Argentine flag, which is called Argentine flag sign. Now, I always do a small Rhexis, decrease the intralenticular pressure by aspirating some cortical lens matter, peripheral cortical lens matter. In this case, some air bubble entered into the antechamber and my visibility was disturbed. Now what I am planning to do is to come out and use only the irrigating probe of bimanual IA. Here it is. The irrigating probe of bimanual IA is taken and it is introduced into the anterior chamber and I start irrigating the anterior chamber, and I now go into the capsular bag through the small Rhexis opening, through the mini Rhexis opening, and see the big chunk of cortical lens matter has come out through the main incision, and the nucleus is freely mobile by this time, and hydrodissection has already occurred. That's it. Enough of intralenticular pressure has been reduced. Now I inject viscoelastic substance and I am injecting HPMC. If you want, you can use sodium hyaluronate, but I find that it is very much possible to do Rhexis only with SPMC with this technique. Now I cut the margin of the Rhexis gently with a Vanna scissor. Since the eyeball is having some jerky movement, I want to hold the eyeball with fixation forceps. I take utrata forceps. I hold the capsular tag. There it is. I fix the eyeball, hold the capsular tag, and I enlarge this Rhexis. At this time, I try to be at equal distance all around from the margin of the Rhexis, and in this way I will be able to achieve a round Rhexis. Now we can see that this is a fairly round Rhexis, almost circular. Now in this case I am going to show vertical chop. This is a little bit of viscoat, and underneath I am injecting SPMC. This viscoat will protect the corneal endothelium very nicely. Now is the time to enter into the eye with the tip of the phaco handpiece. Here it is. The phaco handpiece enters into the eye. The tip is impaled into the nucleus right at the center, and this is vertical chop. When the separation occurs above downward, it is vertical chop. When the separation occurs at the iris plane horizontally, it is horizontal chop. So 4 fragments have been made in this case, and each fragment is emulsified and removed. In this case, phaco power was 55%, flow rate was 45, vacuum was 450. This is the last nuclear fragment. I remove the chopper. The antechamber becomes deep, the posterior capsule goes backward, and it becomes very safe to emulsify the last piece remaining at the center of the pupillary area. And now I inject viscoelastic substance and clean the cortical matter. The cortical lens matter can be cleaned with bimanual irrigation aspiration, with coaxial irrigation aspiration, or this very simple instrument. It's a Simcoe cannula. This is used in SICS, and I am using the same instrument for cortical cleanup in this surgery. This is a 23 gauge direct Simcoe cannula from Appasamy Associates. And now cortical cleanup is nicely done. And now in this case I am going to use a 3-piece intraocular lens, multi-piece also as we call it. In this case I have selected Technis multi-piece intraocular lens. It's a beautiful lens. Technis technology is really beautiful, and the material is very good. Though I have no financial interest, for the interest of the patients I must say that this is a very good lens. I haven't seen glistening in these lenses. I have implanted Technis 1 in a 11-year-old child with developmental cataract. I am following up that child for the last 5 years. The lens is very clear and there is no glistening. Main incision has been enlarged to about 3.1 millimeter, and now see how I load the intraocular lens. I'm going to decrease the magnification so that I can show you clearly how I load the lens. Here it is. The lens is placed in the cartridge. The magnification is being decreased further. The lens goes into the groove from outside. And now I depress at the center and gently fold the flaps. Depress the flaps and the lens gets folded. This is the injector. This is the groove in the injector. It is placed there. Now see, this trailing haptic should not be there. It should be outside like this. And I place it outside with the help of a Sinskey hook. Now the plunger goes gently forward, and in this case I have to use both hands. I have to screw with my right hand and hold the hub of this system with my left hand. First I go into the eye. Now I give the chopper to my assistant, hold the system with my left hand and screwing is clockwise, but the system moves anti-clockwise with your movement of the left hand. The trailing leading haptic has gone into the equator of the capsular bag, and the trailing haptic is placed like this in the capsular bag with a lens holding forceps, with a thick, stout MacPherson's forceps. Now the lens has gone into the capsular bag. A thorough irrigation of this viscoelastic substance is necessary. Irrigating the anterior chamber now. Now going behind the IOL, you can see that some white material sticking to the optic of the intraocular lens, and I'm thoroughly irrigating those white materials out. It's nicely cleaned now. And now I'm going to take irrigation aspiration system. This is the irrigating probe of bimanual irrigation aspiration. Irrigate the anterior chamber. Now I go behind the intraocular lens, irrigate the space. You must be very gentle. The pressure should not build so much that the posterior capsule ruptures. We must keep the way open so that the fluid can come out along with the viscoelastic substance. Now I am using irrigation aspiration both together and thoroughly cleaning the viscoelastic substance. It is very important to see the happy face of the patient. Unless you clean the viscoelastic substance, intraocular pressure is going to rise. The patient will have a lot of discomfort, even pain in the eye, if you don't clean the viscoelastic substance nicely. Now the side ports are hydrated. Moxifloxacin has been injected into the antechamber. Whatever moxifloxacin remains after the final wash, that works in my cases. And this is the final wash with higher magnification. I examine the antechamber. If any cotton fiber, any particulate matter, anything is left in the antechamber during this final wash, and this final wash is given with BSS. Even for free cases, whenever I do surgeries with ringer lactate, this final wash is given with balanced salt solution. A nice balanced salt solution remains at the conclusion of surgery, and the outcome is excellent. Thank you very much for watching.